It's the Pain Exam Podcast with your host, David Rosenblum, MD. If you treat pain or have an interest in pain management, join us as we discuss painful disorders, alternative treatments, practice management, and more. Be sure to subscribe to the Pain Exam newsletter at painexam.com and review the podcast on Stitcher or iTunes. Our high-yield premium episodes are now available on the Pain Exam app with a premium subscription or access for free with a CME subscription at painexam.com. And now, without further ado, here's your host, Dr. Rosenblum.
After all these years, I don't think I've ever done a podcast on carpal tunnel syndrome. And now that I'm beginning to suffer from it, I figured I would delve into this. Before I do, a lot of things coming up. I just got off of a bunch of trips in which I did a course in Canada. We did a private group of 30 docs, interventional pain docs, and docs who are less interventional, a mix, who need to learn ultrasound to keep their skills up and perform procedures in the office mainly. Went great. I have a course in Costa Rica coming up next week and a few in New York. Remember, we have board prep for pain docs. It's a refresher board review course with myself and Dr. Al Abdul Saeed in New York in June, as well as regenerative medicine course again in May. The last one went very well, and every time I do these courses, I'm tweaking them a bit to give you more value. Anyway, speaking of regenerative medicine, carpal tunnel is something that I tried after a review article on using PRP. Unfortunately, the benefit was not apparent with my patient. Nevertheless, I still decided to try it on myself. And it's only been about 3 weeks, so I'll let you know how it goes. But I do believe in PRP for a lot of things. Of course, it's not going to work for everything. However, I figured rather try that first than a steroid shot first, because generally speaking, this is just generally speaking, and not for every problem, of course, the PRP tends to last longer than steroid injections, and it does take longer to work. So I'm only 3 weeks out, so hopefully it will work. Anyway, let's talk about carpal tunnel syndrome. So it's an entrapment neuropathy caused by compression of the median nerve as it travels through the wrist's carpal tunnel. It's the most common nerve entrapment neuropathy, accounting for 90% of all neuropathies. Early symptoms of carpal tunnel include pain, numbness, paresthesias. The symptoms typically present with some variability in the thumb, index finger, and middle finger, and radial half thumb side of the ring finger. It can also radiate up the arm. There can eventually be decreased fine motor coordination, clumsiness, and thenar atrophy. In early presentation of the disease, the symptoms are usually at night when lying down and are relieved during the day. With progression, the symptoms will be present during the day, especially during certain activities like drawing, typing, or playing video games. And they can become constant, which could obviously be a big problem. You see these in people who tend to use computers a lot, like myself, and those who have jobs where there's a lot of vibration, like construction workers. So in terms of pathophysiology, there's a compressive element, including a detrimental cycle of increased pressure, obstruction of overall venous outflow, increasing local edema, and compromising the median nerve's intraneural microcirculation. Nerve dysfunction becomes compromised, and the structural integrity of the nerve itself further propagates the dysfunctional environment. The myelin sheath and axon develops lesions, and the surrounding connective tissue becomes inflamed and lose normal physiologic protective and supportive functions. Repetitive traction and wrist motion exacerbate the negative environmental, further injuring the nerve. In addition, any of the 9 flexor tendons traveling through the carpal tunnel can become inflamed and compressing the nerve. Sensory fibers are often affected before motor fibers. Autonomic fibers that are carried in the median nerve can also be affected. So, on examination for sensory, there may be abnormal sensation in the palmar aspect in the first 3 digits. The motor exam may display wasting and weakness of the first and second lumbricals, opponens pollici, abductor pollicis brevis, and flexor pollicis brevis. You could do the Hoffman's Tinel sign, which is a low sensitivity and specificity test that's commonly performed. Tap on the carpal tunnel to stimulate the median nerve. Positive symptoms occur when the symptoms are reproduced. The carpal compression test is the best test. It's done by applying firm pressure over the carpal tunnel for 30 seconds. The test is positive when paresthesias, pain, or other symptoms are produced. Fallon's sign, or the reverse prayer, is by having the patient fully flex their wrist by placing dorsal surfaces of their hands touching each other for 1 minute. It's positive when there's reproduction of numbness, tingling, paresthesias. The reverse Fallon test. This is the reverse Fallon or prayer test, which is having the patient extend both of their wrists by placing palmar surfaces of both hands together for 1 minute as if praying. Again, a positive test is with reproducing symptoms. The palpatory diagnosis, another palpatory, is a test in which the examiner puts soft tissue over the median nerve for mechanical restriction and reproduces symptoms. The square wrist sign, the test is an evaluation to determine the risk of developing carpal tunnel syndrome. The test is positive if the ratio of thickness of the wrist divided by the width of the wrist is greater than 0.7. This is one I never used before, so I'm not really familiar with that one. MRI is good for looking for space-occupying lesions, which I would imagine are rare. Ultrasound can also identify any space-occupying lesion, and also can detect abnormalities in the median nerve, like increased cross-sectional area that can be diagnostic. Ultrasonography can also help guide steroid injections to the carpal tunnel. EMG and nerve conduction studies are also used for diagnosis. These findings can confirm the diagnosis. Abnormalities on electrophysiological testing and associated with specific signs and symptoms are considered the gold standard for carpal tunnel syndrome. EPS testing is also assessing the damage of the nerve and can also determine prognosis. It's usually divided into mild, moderate, and severe. In mild, the patients have sensory abnormalities alone, and in severe, there's also motor. So in terms of management, physical therapy, the braces for the wrist, this can be through proper hand ergonomics, such as placing the keyboard at proper height, minimizing flexion, extension, abduction, adduction with the hand when typing. It should be recommended to decrease repetitive activities if possible. Counseling on weight loss and increased aerobic activity can also help. A properly fitting nighttime wrist splint can be helpful. An occupational therapist trained in hand therapy may also be a beneficial referral. Combined therapy may be more beneficial than any single treatment, and a short course of NSAIDs can help relieve symptoms, but but some feel it doesn't help enough. So, if conservative treatment fails, a steroid injection to the carpal tunnel can be beneficial. Steroid injections may be beneficial before surgical management or when surgery is contraindicated. Median nerve measurements by ultrasound can predict response to steroid injections. NSAIDs may be useful against carpal tunnel syndrome with wrist flexor tendinitis. Similarly, diuretics can help in patients with fluid overload, gabapentin, pregabalin, which are used in types of different of neuropathic pain. But there's no oral agent better than placebo, according to the American Academy of Orthopedic Surgeons. So that's kind of, I guess, pushing more patients to surgery, stated by the surgeons. But if it's true, then why are we even bothering with NSAIDs? Surgery. So surgical decompression can be performed in patients who have electrophysiological testing that's positive and persistent carpal tunnel symptoms and maybe show significant axonal degeneration. The release is performed by a neuro-orthopedic or plastic surgeon or hand surgeon, usually a hand surgeon in my practice's case. It can be performed open or endoscopically. The release is considered a minor surgery in which a transverse carpal ligament or flexor retinaculum is cut, opening the space in the carpal tunnel, decreasing pressure on the nerve. It does not require hospitalization, and 90% success with low complication rate. As a pain doctor, unfortunately, I've seen complications such as RSD or postoperative pain, and hence my apprehension for going for surgery. I haven't even done a steroid shot yet, so I'll probably do that. So, guidelines by the American Academy of Orthopedic Surgeons. Thenar atrophy is strongly associated with ruling in carpal tunnel, but is poorly associated with ruling it out. The Fallon's Testinel sign, flick sign, upper limb neurodynamic tension, nerve tension test criteria should not be used as an independent physical exam maneuvers to diagnose carpal tunnel alone because it has a poor or weak association with ruling out this condition. The independent history interview topics should be used to diagnose carpal tunnel syndrome because alone each has a poor or weak. It should not be used. The history should not be used alone because it has a poor or weak association with ruling in or ruling out the condition. The following factors are associated with an increased risk of developing carpal tunnel syndrome: perimenopausal, risk ratio index, rheumatoid arthritis, psychosocial factors, distal upper extremity tendinopathies, gardening, assembling line work, computer work, vibration, tendinitis, workplace fall, forceful grip exertion. Physical activity exercise associated with a decreased risk of developing carpal tunnel syndrome. The use of immobilization, brace, splinting orthos should improve patient-reported outcomes. The use of methylprednisone injection should also help. There's no benefit to oral carpal tunnel syndrome treatments, diuretics, gabapentin, astaxanthin capsules, which I'm not familiar with, NSAIDs, pyridoxine, or placebo. Oral steroids could improve patient-reported outcomes in comparison with placebo, and the surgical release of the carpal tunnel ligament does relieve symptoms and improve function. Surgical treatment should have a greater therapeutic benefit of 6 to 12 months in comparison with splinting, NSAID therapy, and single steroid injection. There is no benefit to routine postoperative immobilization after carpal tunnel release. And there's a whole bunch of differentials: cervical disc disease, mononeuritis multiplex, multiple sclerosis, diabetic neuropathy, cervical radic, overuse, traumatic brachial plexopathy, radiation-induced brachial plexopathy, neuropathies, tendinitis, tenosynovitis, and thoracic outlet syndrome. Prognosis: it's a progressive disease over time. It can cause permanent damage to the median nerve. The syndrome recurs to some degree even after surgical manipulation, up to one-third of patients after 5 years. Almost 90% of mild to moderate carpal tunnel cases respond to conservative therapy. However, many patients progress to requiring surgery. Patients with carpal tunnel syndrome, secondary diabetes, or risk factor tend to have less favorable prognosis and do not than those with no apparent underlying cause. Patients who have normal electrophysiological studies have much less favorable outcomes than do individuals with abnormalities on those tests, and also more complications. Axonal loss on electrophysiological testing is a poor prognostic factor. So basically, in terms of deterrence and patient education, avoid repetitive hand motions, holding onto vibration tools, heavy grasping and positioning, or working with your wrist bent and out. Quit smoking, lose weight if overweight, reduce caffeine intake. I'm not sure why caffeine intake is effective, but that's what they recommend. A wrist brace will sometimes decrease the symptoms. Keep the wrist in a resting position, not bent back or too far. The brace can especially be helpful for relieving numbness and pain felt at night, because your hands can curl as you sleep. It could also be worn during the day, and consult with an occupational therapist. Other pearls: the carpal tunnel includes the median nerve and 9 flexor tendons. The flexor tendons can include 4 tendons from the flexor digitorum profundus, 4 tendons from the flexor digitorum superficialis, and 1 tendon from the flexor pollicis longus. The transverse carpal ligament, or the flexor retinaculum, makes up the superior boundary, and the carpal bones form the inferior boundary. Anyway, I hope that helped you guys for your boards, for your careers as pain docs, or in my case, as a patient. Be sure to check us out at painexam.com and my new site, the nrappain.org, where I am moving my board review for anesthesia, PM&R, pain, and also some ultrasound pearls and educational materials. So check out either painexam.com, our events page, or our board review, as well as the nrappain.org page. Thanks. Hope to see you guys at the conferences or courses. Take care, good luck, and have a great day.
Dr. Rosenblum is here solely to educate, and you are solely responsible for all your decisions and actions in response to any information contained herein. These podcasts are not intended as a substitute for the medical advice of a physician to a particular patient or specific ailment. You should regularly consult a physician in matters relating to yours or another's health. You understand that this podcast is not intended as a substitute for consultation with a licensed medical professional. Copyright 2017, David Rosenblum, all rights reserved. No part of this publication may be reproduced, stored in a retrieval system, or transmitted in any form or by any means, electronic, mechanical, recording, or otherwise, without the prior written permission of the author.